Welcome to Aging with Down Syndrome. Here you will meet families who have cared for and assisted their loved ones to live their best lives. Through conversations, the Aging with Down Syndrome podcast will shine a spotlight on the efforts of families and professionals supporting individuals with Down syndrome through their senior years. I'm Jadine Ransdell, Matt's mama. I'm so excited to have Dr. Brian Chicoine in the studio with us today. Dr. Chicoine is the medical director of the Advocate Adult Down Syndrome Center in Park Ridge, Illinois. And today we've asked Dr. Chicoine to chat with us about some of the health issues he has found to be prevalent in our older adults. But Brian, before we start, would you first remind our listeners about who you are and how you started working with adults with Down syndrome?
Thanks, Jadine. Thanks for having me. As Jadine mentioned, I'm Brian Chicoine. I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center. We're in Park Ridge, a Chicago suburb. Our clinic opened in 1992 when Sheila Hebine from the National Association for Down Syndrome, which is our local Down syndrome organization, or one of the local Down syndrome organizations, came to the hospital because they were finding their children were getting good care as kids, but not good care as adults. And so they requested a clinic be opened or some service be provided. I had practiced in a smaller community in the northwest corner of Illinois and took care of two of the residents of two 16-bed residential facilities for adults with intellectual disabilities, and had come back to the hospital to join the faculty of where I trained. So I had interest and some experience, and we started 2 mornings a month. And like the Field of Dreams, if you build it, they will come. And over the course of time, we've seen about 7,000 adolescents and adults with Down syndrome since we started.
Okay. How many did you say that you've seen?
About not quite 7,000.
Oh my gosh. So this is why we asked you to come on and give us your perspective. I think you're unique in this field in the amount of patients you've seen with Down syndrome and the amount of adults that you've seen. So can you highlight for us the most prevalent or the most common issues that you've seen in our adults who are aging?
Yeah, certainly we know that both from research and experience that people with Down syndrome do experience sort of an earlier aging process. And so a number of health conditions that we see more commonly as we get older do occur often at a younger age in people with Down syndrome, and some of the conditions occur more frequently as well. Although I should comment that there are some conditions that occur less frequently as well. So it's not all challenging news, but there are some things that occur less frequently. But certainly of the things that occur more frequently, the biggest obviously is Alzheimer's disease, unfortunately. And that's now estimated that the lifetime incidence of Alzheimer's disease in people with Down syndrome is about 95%. So it's very, very, very common, unfortunately. And there are another number of other health conditions. Sleep apnea, very common. A lot of endocrine conditions, including hypothyroidism, underactive thyroid, overactive thyroid is more common. So a number of health conditions, but Alzheimer's is the biggest issue.
So as our folks are aging and we see changes, what's your advice to families as we start noticing changes? I mean, Alzheimer's is a pretty big word. It's very scary. I have learned a lot about it in the last 10 or 11 years. But what advice would you give to families as, they've got these adults and now they're starting to, they've hit their 40s and they're starting to see changes. What would you suggest to them?
Yeah, that's a great question. I would go back a step even before they get to adulthood and look from earlier on in life. What do we know from, we don't have a lot of good data in folks with Down syndrome. We have some, but, what can we extrapolate from the data we know from the rest of the population? And that is, what are the things we can do to either slow down the onset or prevent the onset of Alzheimer's disease around exercise and healthy eating and stimulating, doing activities that stimulate the brain, social interaction, making sure we're hearing well, and all those things. We want to start that at a young age and really making sure those things are being addressed, taking good care of our health in every way that we can. It's certainly not a guarantee that it'll prevent Alzheimer's disease, but it might prevent it in some situations, but it certainly may delay it as well. Although we do need more research on that. But once the changes, once people start noticing changes, I think one of the things that's really important is to understand is that Alzheimer's disease is still a diagnosis of exclusion, meaning you really want to make sure you're looking at other factors. And so maybe there be other reasons that may be contributing to the decline, or maybe there's something that's also there in addition to the Alzheimer's disease. So it doesn't mean you don't want to still address that. So we know that people with an underactive thyroid, for example, can their cognition, their thinking is slowed down. Their memory can be impaired. It can affect their mood, sleep apnea, vitamin B12 deficiency. All these things that are more common in people with Down syndrome can also cause cognitive decline, just like as does Alzheimer's disease. So we want to make sure we're looking at those other things as part of the assessment, so we're not overlooking, something else that as of November of 2025, we know is more reversible than Alzheimer's disease. But hopefully that'll change as well as we go into the future, that we'll be able to address Alzheimer's disease as well and either reverse or prevent that as well with a variety of either medications or interventions. The third part of that then is we want to really think about screening. In the global medical guidelines, we concluded that it started at age 40 with screening, but now a number of people are now looking at that and suggesting maybe even 35, maybe even 30, we should start to look for decline and what is going on, and of course then look for those other reversible causes, but also then start to look and see, is this Alzheimer's disease, and what can we do about that? How can we prepare for the future? And ultimately, hopefully there'll be other treatments that we can do to treat that better as well. And then the fourth thing I think is really important is research. We really need to know more about addressing this in people with Down syndrome. As Hampus Hillestrom, who's now with the National Down Syndrome Society, said at a conference a year or so ago, 17,000 people were studied in these newer medications for Alzheimer's disease, and none of them had Down syndrome. So we really have not, included people with Down syndrome in these important studies for us to really know that, do these medications work in people with Down syndrome? Are they safe? And so that's now being rectified, and we're starting to see these studies be developed. And it's going to really be important that people with Down syndrome and their families participate, so that we really can get a better sense of, what are the interventions that will work and can help either prevent or treat Alzheimer's disease in people with Down syndrome.
Brian, that brings up something for me, and I know it's something that you have talked about and actually written about. As you were talking about, the diagnosis of exclusion, Matt received his diagnosis of Alzheimer's. He was 39 years old, and it was we're seeing this, and this, but not consistently, but it's changes, and, he seems confused some days. And his neurologist at the time, not the current one, but his neurologist at the time said, well, he's almost 40, he has Down syndrome, so this is Alzheimer's. And there were no other tests run. It just, this is what it is. And I've had that happen in Matt's life before, where he also has an autism diagnosis that he did not receive until he was in his mid-30s, because in the 70s, the late 70s, when I was questioning it, his doctors were saying, no, what you're seeing is Down syndrome. It's I think it's called diagnostic overshadowing. And so what I'm hearing you say is there's a bit of bias in how we're treated, how our loved ones are treated, because of that diagnostic overshadowing, or the inability, or the not wanting to do things to rule things out, but just let's get to a diagnosis. What would you say about that?
Yeah, the two very important points you brought up, and we could probably speak an hour on each of them, but I'll try to really make this shorter. First is the issue of bias. Let's address that first, and that is unfortunately still an issue in the medical community for many people with Down syndrome, that they're not treated the same as others, and I don't mean they should get the exact same care as others in the sense of treat what everyone has, because as I mentioned before, some of the conditions are more common, some are less. We want to make sure we're, using the healthcare that's really directed specifically at the needs of this population, or the individual with Down syndrome. But in a sense that, hopefully if or when, or maybe it's already happening, but, when I go to the doctor and I'm declining in my cognitive skills, hopefully the doctor has the courtesy to do a workup to see, is there something else other than Alzheimer's disease? And unfortunately, people with Down syndrome don't always get that. And so, that really is a bias. And then that kind of leads to the second point, the diagnostic overshadowing, which I just think I have just become so fascinated by, and I talk a lot about this because I think it really does impact the healthcare of people with Down syndrome. And I'll take a step back, a little history. Back in the 80s, and I don't remember who the author was, but wrote about diagnostic overshadowing with regards to having an intellectual disability. And so in the sense that every symptom that person presented with was just said, it's just, in our case, Down syndrome, or it's just, having an intellectual disability. And so, if it was a behavior change or a incontinence of urine or autistic-like symptoms, it was just blamed on Down syndrome, and there was no workup. And then, of course, we know that those conditions, all those things, can have potential different treatments than you would if you don't have those conditions. So really, people got overlooked both from a diagnostic and a treatment standpoint. So those things were not addressed. And similarly with Alzheimer's disease, because we know that Alzheimer's disease is more common in people with Down syndrome, as soon as someone starts to decline, it's just assumed that it's Alzheimer's disease. And again, they don't get the courtesy of a good evaluation. So, I say that I've been really contacted from people all over the world who reached out and said something similar to this. My 19-year-old son or daughter has been diagnosed with Alzheimer's disease. And I say, well, I've learned never to say never in medicine, because as soon as you get cocky and say never, then you're going to see the one case. But this is about as close to a never as you're going to get, and so really there are many other reasons for that, and we really want to look at those. And clearly the Down syndrome regression disorder, which we're calling here in the States, is really for a 19-year-old to be much more likely than Alzheimer's disease. But it could also be thyroid, B12, sleep apnea, and many other things. So it really important before we knew what the term diagnostic overshadowing, we called it just the Down syndrome. And so it's really important to not just label it just the Down syndrome, but it's also important not to label it just the Alzheimer's disease, and really make sure we're looking at people and giving them the fair shake at a good assessment.
So, Dr. Chicoine, we had an instance with my brother Matthew where he was diagnosed in his early 30s with Alzheimer's, or as they labeled it, early onset Alzheimer's. And we later came to find out that that was a misdiagnosis since he was so young. What would you say is the average age to start looking for signs of Alzheimer's versus other common aging issues that may be worth looking into with your care team, primary physician, that could possibly be another health issue that families are facing instead of actually Alzheimer's?
I assume you're asking about people with Down syndrome and not me, but we'll jump. We'll jump to the people with Down syndrome. We'll try to stay on topic. But so that the studies show the average age is about 52 to 54. And in general, it's thought that probably uncommon before 40, although it does occur sometimes. And so, again, someone in their 30s, even in somebody in their 50s, we want to make sure we're looking for other contributing causes, whether it's the primary cause or whether it's an additional cause. We definitely want to look for those. But definitely in somebody in their 30s, you really want to look for other things. And it can be so many things. And we talked about some of the health issues, but it can be some of the psychological issues too. Those times of life where oftentimes other family members will leave the house, will get married, will have their own children. The life circumstances changes. Sometimes their parents are getting older and having more difficulties themselves. And so there's lots of challenges in life, around that time of life for many of our folks. And, so that can be very challenging for them, and they don't know how to process that. And so it looks like they're declining, but, there's a different explanation for that.
So, Dr. Chicoine, you've given us so much to explore here, and so I will ask your forgiveness for me digging into each one of these as their own separate topic. But it sounded to me like Alzheimer's, thyroid, sleep apnea, B12, these are maybe the most common things that you're seeing in our older adults. Did I get that right?
Well, there are, unfortunately, the list is long.
Gotcha.
Having a extra chromosome not only impacts having the extra chromosome, but it impacts all the other chromosomes, potentially as well. So what the impact of that having a chromosome? So there are lots of health conditions, but yes, the ones that we talked about are some of the ones that are most prevalent.
Okay, I would like to dig into some of those if you don't mind. We can start with sleep apnea, and I'll tell you from my experience with my Aunt Kathy. She had sleep apnea for her whole adult life at least that I know of. And we were never able to get her to comply with a CPAP. And the reason was it never fit her properly, even when they tried to get the small masks. So can you talk a little bit about what the options are for sleep apnea? I'm especially interested in the new option, the Inspire implant, because I think that would have been great for my Aunt Kathy. However, by the time it came out, she was too far gone in her Alzheimer's to be a candidate, and I think as we talk about aging, we can't forget that going under the knife and anesthesia can be particularly dangerous. Am I correct? As you get older and as your cognition declines?
Yeah, that's a good point to consider. And I think certainly weighs heavily in any decision we're making about the potential for surgery or anesthesia in one of our older folks, particularly one who's already displayed signs of decline. In our experience, really for any of us, if we undergo anesthesia, cognitively, we may be sort of a little scrambled for a while after we come out of the anesthesia. Obviously in the immediate postoperative period in the recovery room, but even sometimes, for a period of time afterwards, we're just a little foggy. But most of us recover from that. We find that some of our older adults with Down syndrome, particularly again those that either have been diagnosed with Alzheimer's disease or we're suspecting may have Alzheimer's disease based on some cognitive changes, we find that some of them don't seem to recover from that fogginess. And so, they're declining from the Alzheimer's disease, and then they sort of take a step down, from presumably from the anesthesia effects. And then, instead of getting back up to that curve, that declining curve, now they're at a sort of a new curve that's, several steps below the previous curve. So we're really cautious on recommending anesthesia in our older folks for that. And that's a great example of, you got someone that has sleep apnea. It's not been able to be treated with first, we maybe take a step back. For those that don't know, sleep apnea in people with Down syndrome is typically obstructive sleep apnea. There's another kind, central, where the brain doesn't tell the body to breathe appropriately. But most people with Down syndrome have sleep apnea. It's that the brain is telling the body to breathe, but the airway gets occluded or blocked during breathing while sleeping. And so they're not passing air appropriately. And so the oxygen level in the blood can drop, and that's not a normal way to sleep. And so the sleep cycle is disturbed, and that both of those things can have real impact on cognition, on thinking. And so, and again, this is much more common in people with Down syndrome than in other people. And so the most common treatment is CPAP or BiPAP, which is a mask over the mouth or nose or both. And positive pressure is put in through a machine, through a hose and through the mask into the body to keep the airway open while people are sleeping. And that is a very effective treatment for many people. But like people without Down syndrome, many people with Down syndrome, or probably even more perhaps than people with Down syndrome, find that difficult to use. And that's definitely not unique to Down syndrome. There's a lot of people who don't have Down syndrome who struggle with CPAP. So a newer thing that's been available now is this Inspire, or it's sort of like it's not really, but it's sort of like a pacemaker. It's a thing that's implanted under the skin, and one wire basically goes to the diaphragm, and as the diaphragm starts to contract, it sends a signal to the little device, and then there's another wire that goes to the nerve that stimulates the tongue, and as that signal fires, it sort of pushes the tongue out, and so opens up the airway. And that can be a very effective treatment for sleep apnea as well. It is a couple surgical procedures. Fortunately, you can turn it on and off, so you're not all day long. Your tongue isn't going in and out all day long while you're awake, but you turn it off in the morning and turn it on at night. And generally, we haven't had a huge number of people that have had it. We do have a handful, and they've tolerated it very well and been very successful with it. Now we know in the non-Down syndrome population, one of the newer weight loss medications has now been shown to benefit sleep apnea, and that's probably based on weight loss. And we do know that obesity is more common in people with Down syndrome. It does contribute to sleep apnea in people with Down syndrome, although there are some trim people also who have Down syndrome who also have sleep apnea. But so it wouldn't be for everybody necessarily. And then there's a study about to start has been shown in people without Down syndrome on a small study couple other medications, one that's used for attention deficit and one that's used for spastic bladder. Those two medications together have also been shown in a small study in the non-Down syndrome population to potentially benefit sleep apnea. And that there's a study about to start next year for that in people with Down syndrome. So there are some additional options. I would anticipate there'll be more options as time goes on, because it is one of those conditions that both the diagnosis and the treatment can be challenging, particularly for people with Down syndrome.
Dr. Chicoine, I'm curious what your opinion is after seeing as many patients as you have. I experienced two different providers with two different approaches on how to diagnose thyroid issues. Aunt Kathy was not diagnosed with any thyroid issues her whole life. However, one provider told us that she really should have not just the TSH and the total T4 and total T3, but she should have free T4, free T3, and reverse T3 tested. Now, I had no idea what those things meant before I was told about these things, and I had to look them up. But it seems like it's a more in-depth type of testing. And what she told us was that people with Down syndrome tend to need that more in-depth testing. Otherwise, thyroid issues can be masked or hidden. However, another provider told us that it was not necessary and that we should just have the regular run-of-the-mill thyroid tests. Can you talk about that discrepancy in approaching thyroid diagnosis?
Yeah, I fit somewhere in between there.
Okay.
So commonly only the TSH is recommended, most commonly. And the TSH is a hormone that's secreted by the brain that tells, if it's elevated, it tells the thyroid to make more thyroid. And if there's enough thyroid hormone produced by the thyroid gland, it loops back to the brain and tells, okay, TSH, you can go back down. And then if there's too much of the thyroid hormone being made, the TSH actually goes low. So a high TSH, this is a little backwards. You have to really pause and think about it for a second, because a high TSH is consistent with an underactive thyroid or not enough thyroid. A normal TSH is consistent with normal thyroid function, and a low TSH is consistent with an overactive thyroid. However, there are more data coming out that, in fact, I was just looking at an article, I missed it, it was from a couple of years ago, that, and this sort of just confirmed what we know from experience, is that the TSH can kind of wander in people with Down syndrome. So it can kind of go up and then come down without any intervention. And so it's not, an elevated TSH isn't, if you wait, isn't necessarily going to stay an elevated TSH all the time. And so sometimes maybe it's not necessary to treat just an elevated TSH. So I really, several years ago, I started really doing a TSH and a free T4, because I think that gives more information. And part of that was based on, again, this study was not done in people with Down syndrome, but there was a study done in the non-Down syndrome population that the T4, they looked at TSH and T4 and then looked at people's symptoms. And the T4 aligned more with the symptoms that would be consistent with thyroid dysfunction than the TSH in the non-Down syndrome population. So that one's a hard one, because sometimes the individual who we see can't tell us about their symptoms. And secondly, there's a number of symptoms of thyroid dysfunction that are part of Down syndrome. I mean, not to say that go back to diagnostic overshadow. We're not to blame it on Down syndrome, but there are some some overlap there. So it does make it challenging. So I really started go to the TSH, doing the TSH and the free T4. Now, all those other tests, some of those are significantly older tests and are not as used as frequently. I have not found any literature that would support doing all those things. I know there are some practitioners that find that helpful. I personally have not found any literature to support to do them. So I stuck with the TSH and the T4. Not to say I have all the answers, but that's just what worked for us. And so again, I was looking at this article recently, and so even in people on thyroid medication, the TSH can kind of go up and down a little bit sometimes. And so it is helpful to have that T4. So if the T4 is normal and the TSH is just mildly elevated, That's if you're not on medication, that's called compensated or subclinical hypothyroidism. And there's a lot of debate, should that really be treated in people with Down syndrome? And one study I found that treating it or not treating it, for example, didn't change weight. And so, we know that an underactive thyroid is associated with weight gain. But in this case, treating subclinical hypothyroidism, where the TSH is a little elevated and the T4 is normal, did not help people lose weight. So that would, and in the pediatric world, they've really not found that changes cognition to treat subclinical hypothyroidism. So there's significant, maybe debate's not quite the right word, but there's certainly a need for continued study for that. I think there's a lot we don't know. But the other thing this paper said, that even in people on the medication, if you come in, your TSH and your T4 are normal, and then 6 months later you come in, your TSH is high, but your T4 is still normal. That can sometimes just be sort of the natural ebb and flow in people with Down syndrome. And so one way to do that would be to go ahead and bump up the dose so that you get that TSH back in the normal range. The other thing is to wait a little while and just repeat it and see if it doesn't come back normal itself. So different approaches. I've kind of really tended more now at this point to just check it again more frequently, because I've seen too many times chasing that TSH and not looking at the T4 and not listening to the person's symptoms. We end up making the person have an overactive thyroid on too much medication, and then we're going up and down and chasing every which direction. So that can be challenging. So it is a little more complicated than just treating the numbers, but you do have to kind of stop and think. And again, at least I've not seen data to this point that those additional numbers change the approach.
Thank you.
If I could just go back to, you keep mentioning symptoms with thyroid dysfunction, and other than sometimes, being overweight, what are some other symptoms that we can look for as family members that we might notice to say, hey, something might be off here?
You're reliving my physiology oral exam. I was asked this question 40 years ago and didn't have the answer at that point. So I do have the answer now. Weight, we talked about, dry skin, which is very common in people with Down syndrome anyway, with or without thyroid problems. Constipation, which is very common in people with Down syndrome with or without hypothyroidism. Cognitive impairment, which is, part and parcel pretty much to having an extra 21st chromosome. So there's a number of things that are, can be hypothyroidism and underactive thyroid, or can be Down syndrome, if you will. So a number of things. Fatigue is another big one. So there's a number of things that I wouldn't say that's part of Down syndrome. That would definitely be a symptom that you would think about. You'd want to make sure you're checking the thyroid. So it can be challenging. But on the other hand, Down syndrome may be contributing to some of it, but thyroid may be contributing to some of it. So what is the additive effect? And you don't want to just do the diagnostic overshadowing and say, oh, well, it's just dry skin, that's just Down syndrome, and not think that the thyroid may also be contributing. So it is important to look at those
Thank you.
things.
Dr. Chicoine, can we loop back to the biggie, Alzheimer's? You had mentioned something about, in your practice, helping family members or helping people prepare for Alzheimer's. Can you speak to that a little bit more? What have you found in your experience that means preparing for Alzheimer's?
Yeah, I think the first thing that, again, we don't have definitive treatments at this point. I mean, I think they're coming. I mean, 10 years ago, 15 years ago, I was like, I don't know that I will be around when those finally get here. And what we're seeing in the non-Down syndrome population and the studies about the start in the Down syndrome population, I think are really encouraging. And I think also people are appreciating, someone asked a while back about, why do we see it more in people with Down syndrome? And part of it is that something called the APP gene is on the 21st chromosome. And so because people with Down syndrome have 3 of the 21st chromosome, they have more of this APP gene. And that's associated with the development of excess amyloid, which builds up in the brain and is a contributing factor in Alzheimer's disease. So that's why it seems like people with Down syndrome have more Alzheimer's disease. But I think we're also really, the other exciting thing is I think people are really looking at is there probably are other cofactors. And so I saw a study just recently that's indicated that inflammation is probably one of the cofactors. And we know that people with Down syndrome have a higher levels of inflammation on a chronic basis. In fact, Dr. Espinoza and others have described Down syndrome as an interferonopathy, where the interferon, which is part of the immune system, is cranked up in people with Down syndrome. And what does that affect on inflammation, on the Alzheimer's disease? The fact that we don't have the answer to that yet, but the fact that people are asking the question, I think, is very encouraging. That we're starting to look at, other factors that may be co-occurring at the same time, and sort of all have to line up. And unfortunately, in people with Down syndrome, we know they have extra chromosome 21, so they have more of the APP, they have more inflammation, and so that all those factors may contribute. So really, being able to address all those is really important. So now to get back to your question, and I actually remember this, so that's a step in the right direction. So, what do we do when if we screen and we find some, and one of the screening tests, again, side of a side comment, but one of the screening tests that's really, I think, really gets a lot of use and is very good is a national task group screening tool for Alzheimer's disease and people with intellectual disabilities, and it would be good to share that link if we could.
Yeah, we will. That's a good idea.
But, so that's a real nice screening tool, and so what do we do when we start to find that there are changes? And again, we want to make sure we're looking at the other possible causes. We want to look at the B12s and the sleep apnea and the thyroid and all those other things, diabetes and other things that may be contributing to a cognitive decline. But if ultimately it's clear that it's Alzheimer's disease, and again, hopefully the newer medications, hopefully people participating in research and all those things are taking place. But as of now, we don't have really, the studies have not shown that the older medication for Alzheimer's disease there's really not data to demonstrate that they're effective in people with Down syndrome. And that would be our clinical experience as well. And so what can we do? So really, a lot of it's preparation. I think first and foremost is not accepting, but being appreciative of what the person can do and what they can't do, and focusing on what they can do, and focusing on what they enjoy, and focus on appreciating who they are at this point in their life. And so I think that's a real important first step. I think if people are still fighting, really fighting against this, and expecting the person to be able to do something they're not able to do, I think that's just problematic for everybody, including the person with Down syndrome. I think they end up finding that very frustrating, which doesn't help. And anyone, if you've been around anyone, whether they have Down syndrome or not, that has Alzheimer's disease, they can be frustrated by these changes. And so us heaping it on them is not going to be helpful. And one of the things, just a brief example, a small example, it's recommended that if you come up to somebody with Alzheimer's disease, rather than saying, "Do you remember who I am?" say, "My name is Dr. Chicoine. How are you doing today? Nice to see you, Joe," or whatever. And so really not highlighting that they're having memory impairment, because they're going to find that frustrating. So really, I think that's a big first step. The second step is, what can we do in the environment to promote cognitive and otherwise, mental health for these folks? We were looking at this several years ago in our office, and I slapped myself upside the head. I said, we see a lot of folks with Alzheimer's disease. We do not have a sign on the bathroom door that has a picture of a toilet, so that people find getting to the bathroom easier. Now we do. In their own home, maybe having their picture on their bedroom door, so that they know where it's their bedroom. So if they forget, you can do lots of things like that. The Scottish, I may not be saying their name correctly, but the Scottish Down syndrome group has a wonderful booklet, and we maybe put a link to that too, that I just love. It really talks about just some of the simple things. They don't recommend putting white mashed potatoes on a white plate, because depth perception and vision can become impaired in Alzheimer's disease. So that can be hard for the person to find. Shiny floors, throw rugs, all these things that can be real challenging for these folks. So really starting to make those little changes. And then I think the other thing is appreciate people are going to have good days and bad days. And I think that's a real important thing, because, some days, today they can do X, tomorrow they can't do X, but the next day they can do X. And people will often ask me, well, how do I know he's just not sort of playing with me here? And I said, I don't really. I'm not sure I know that I can tell you a way that you can definitively tell, but that is part of the early part of the disease. And so you're really just sort of appreciating that and running with that, I think, is important. So really, I think a lot of it's just the approach. Ultimately, particularly I say this is the population. Forgive me for going on and on, but this is a unique population in that this is typically elderly parents
Right.
taking care of their children with Alzheimer's disease, and you don't really see that very often.
Right.
I mean, there are a few situations, but not to the volume that we see in the Down syndrome community. So, it's scary to me that an 85-year-old woman with her own balance issues is helping her 60-year-old son who has Down syndrome, is overweight, and is having his own balance issues up and down the stairs. Those are the things we need to start to look at, and how can we help the family.
I love it, because what I'm hearing from you is that the key, the most important thing, at least, I mean, there's the education and the specific tips and tricks and hacks, but you start with a mind shift and a change in approach, which I think is critical. I think probably Kristen and Jadine, I'm seeing nods all around, would agree that it's a change in approach. It's a change in a mindset, thinking about these parents who have spent 40, 50 years trying to empower and having to shift on a dime to having to support, I guess, go from empowering to helping, and put the brakes on the empowerment push, right?
That's a real important point. We run in, it's not only families, but it's staff too of day programs or residential facilities or work sites or whatever the case may be. They spend so much effort habilitating, trying to teach people new skills, and they're doing that with everyone else that they're working with. And then the individual with Alzheimer's disease, to some degree, I mean, at the beginning, that still may be important, but as the disease progresses, that's going to become less and less the issue. And so they too have to shift gears and really focus on, is there anything we can do to help maintain skills? Is there anything we can do to supplement the support so that the person can continue to do those tasks on their own as much as possible?
Brian, I'm like right in the throes of all of this right now. And I wanted to circle back because, I know we focused a lot on Alzheimer's today, but I just want to remind our listeners that, if they have someone in their life that's entering their 40s and starting to slow down, that, we don't have to just jump on the Alzheimer's bandwagon, that we need to recognize that, I started slowing down when I hit my 60s. I've revved up now that I'm moving into my late 70s. I've got a new sense of energy from somewhere. But the reality is, our kids at 40 their bodies are functioning like we do at 60. Our kids at 50 are 70, 75. We all slow down. So if we have a 40-year-old who's dragging, getting ready to go out and do their day, we need to appreciate that it's not that they're being lazy. It's not that they're being stubborn. It's the fact that their bodies are starting to slow down. And it doesn't mean it's Alzheimer's, and I think there's just so much that as those who love people who are aging with Down syndrome, that we need to remember so that we can give them the best that they can be, help them be the best that they can be for whatever years they have left. But I also wanted to talk a little bit, you and I have talked about this in the past, but it's something that you have shared is important to you, and that's the opportunity to give our kids, our loved ones, the dignity of risk. Can you talk a little bit about that? That goes, I'm an old mom. I'm an old mom, and I remember when that topic was the hot topic about dignity of risk for our folks with disabilities. So could you talk a little bit about that before we close today?
Yeah, and that'll actually just a nice lead into something I wanted to make sure we talked about as well. But the dignity of risk is a concept about, there was a theologian and a pastor, I think, but back in the early 70s, and really talked about, he used an old term, but so we use the term intellectual disability, but, really allowing people to make choices, even if they're what you and I might consider bad choices. But then we all have that. I mean, not all of us eat what we should, don't smoke and don't drink more than we should on a Friday night or whatever the case may be. So we all have that opportunity to make bad choices, and so really the concept of dignity of risk is that people with Down syndrome should be allowed that same dignity. They should be allowed to make the bad choices. But oftentimes, when you look at how that's defined, for example, a staff person will come in with a person with Down syndrome and he's eating poorly or he's not exercising, whatever the case may be. And the comment often is, well, he has rights. And I say, you are absolutely correct. He has rights. But it really doesn't have to be this dichotomy of either complete freedom to do whatever you want or complete control. The middle ground is education, and so we really want to use that to, hopefully, like any of us. So if I'm making a bad choice, a not healthy choice, let's call it a not healthy choice. Hopefully my physician or my wife or somebody is going to say, there are some other options, and this is a healthier option or that's a healthier option. And so we want to really do that with people with Down syndrome as well. So our approach really is not that if we should help people with through this education, but how. How do we best share this with people with Down syndrome? What are the ways? We know that people with Down syndrome tend to be great imitators, and so I always have to ask if you have a basement where you live, because we have basements in Illinois, but not everywhere, but they're common. It's unlikely that the person with Down syndrome is going to be enthusiastic about going down into the basement to ride the exercise bike while the rest of the family is upstairs watching television and eating ice cream. And so, how do the rest of us demonstrate what that healthy behavior is? And then how do we teach? Are there visuals involved? Are there videos? Are there things that we can do to try to promote healthy living? And certainly making it fun is always beneficial for all of us, and that's a good way. So again, I think that if I may take that one more step, is I think that we've talked a lot about the health challenges. But healthy aging is an important concept in people with Down syndrome as well. And really, for all of us, you want to start, if you haven't been doing it, start wherever you are. I mean, so, if you're 80, start at 80. But if you're 10 or 12 or 15 or 20, and that's an even better time to start if you're still at that age. So healthy aging really starts when we're young. And so really trying to promote those healthy choices, encourage activity, make it family events, so the person can follow suit of what other people are doing as well. And so really try to really make that part of daily life is so important. And hopefully we don't know, a lot of this hasn't been studied as well in people with Down syndrome as it has in the rest of us, but hopefully the downstream advantage will be significant for folks with Down syndrome as well.
You've shared some really great pieces of information today, Dr. Chicoine. And before we close out, I just want to reiterate something that you said earlier that really hit home for me. And it was so useful in our experience with Matthew as he was going through the journey with Alzheimer's, but also to speak to what Jadine said, the whole part about meeting them where they're at, meet them where they're at, and meet them where they're at today, because today isn't going to be like yesterday or tomorrow. And then you also said, not every day is good, but the one thing that helped us is, and you're completely right on that, is to piggyback on what you said, though, find the good parts of each day. There's always a good part of each day. And whether that's in the aging, slowing down process or in the midst of the Alzheimer's journey, I think those two pieces of information that you spoke to earlier can be really helpful to for our listeners, and to help remember when we're dealing with our loved ones, because the frustrations are there and the emotions are there and things get heightened and it's not always easy for the caregivers. But if we can keep those two things in mind, like you said, meet them where they're at today and find the good parts in each day, I think that's just something that is really helpful in it was to us, and I hope it can be to others. But thanks for bringing out those points as a provider, because we don't always hear those types of pieces of information from our providers.
Yeah, I really second that, and I encourage that. And if I can do just a little plug for helping providers learn a little bit more about taking care of people with Down syndrome. We, with the National Down Syndrome Society, we developed the CARE Down Syndrome program, and it really gives a lot of good information. It's designed for primary care health professionals, and there are a couple of articles written around sort of variations of that topic. How do we really meet people with Down syndrome where they are in the office and other places, and how do we support them and help them function as well as they can and get the most out of each day, as well as office visits, et cetera. So I that is such an important point, and I appreciate you reiterating that. Thank you.
Wow, what an amazing conversation we've had. I'm blown away with the depth of it, the richness of it, and just how much we've been able to cover in this short time together. And I just want to say thanks to Brian again, to Dr. Chicoine, for joining us and sharing the knowledge that you've gained. You talk about how much you've learned from our loved ones, and I know all three of us can talk about that as well, because I believe they are life's greatest teachers. So thank you, Brian. I do want to remind our listeners that we will have links to Dr. Chicoine's resource library from the Down Syndrome Center. It's amazing. And just yesterday, I was on it again, looking for some information specific to something that's going on with Matt. And it was very helpful. I was able to get some links, and we'll be able to share that with Matt's doctor. So I'm so grateful that you and the folks at the clinic thought to put that resource center together for us, because I use it a lot. So if you've heard the podcast before, you know that I like to end our podcast with a quote. Today, when I was searching for something on healthy aging, I came across this one that's attributed to what I consider a very wise man. Abraham Lincoln once said, "In the end, it's not the years in your life that count, it's the life in your years." And as an older mom, I can say exclamation point, exclamation point, exclamation point, because I'm finding that as I'm aging, the more life I exude, the better my life seems to be. So, and I think that's what we're trying to get across with this podcast, is to share that how we support our loved ones as they age, and helping them grab on to every piece of life that they can. That's what's most important. So again, I want to thank you, Brian, for joining us, sharing your wisdom, sharing your expertise, and just hoping that, the families and the providers who listen to us will be able to gain something and, support their loved ones even more as they're aging with Down syndrome, because it's quite a journey. It's an amazing learning experience. So thank you.
Yes, thank you.
Thank you for having me.